Hi, everyone. My name is Tina Purnat. I'm a team lead for Infodemic management in WHO Geneva, and I was asked to speak a little bit today about the COVID-19 vaccine demand and its intersection with the infodemic, and how we could learn from the experience for preparing for the next pandemic. So first, I just want to start with basically reminding us that the willingness to receive a vaccine falls on a spectrum. It's not binary of refusing or asking or demanding a vaccine. Actually, most people fall somewhere in the middle, or they may have questions. They may want more information before they take action, and they may also take on this approach of wait and see before they decide whether to take the vaccine. And there's actually many factors that affect vaccine uptake. What I'm showing here is the WHO behavior and social drivers model that was developed based on the best available evidence by a WHO scientific advisory group. And as you can see here, there's factors that affect the vaccine uptake may be related to risk-benefit perception, or social processes, basically existence of social norms that getting a vaccine is beneficial. Then factors related to motivation that basically affect intent to get vaccinated. And then there's a bunch of practical issues that also need to be in place so that the person actually takes the action to get vaccinated. And these are practical, and so availability, affordability, and ease of access to vaccines, or the person's experience of the service when they're getting immunized. Now, at the same time, what we also need to remember is that we live in a very noisy information environment. Everyone that's deciding to take the step in a vaccine, well, actually, we all live in this. So we all seek information from friends, family, and via phone screens every day. And we get constant streams of new information, and that can feel overwhelming. And this is especially true during emergencies, where especially then, because of that acute crisis, there's even more information that surges of different quality, including misinformation. And that can create even more challenge in recognizing credible, accurate health information from misinformation. Now, what I'm showing here is that the digital information environment can impact vaccine confidence and uptake, because in the information environment, there's a very different type of media input into common vaccine narratives, including misinformation. And these in turn can affect people's knowledge and awareness and intent, vaccine confidence, and perceptions of risk. And that's particularly important for vaccines. So that's really important to reflect on. The majority of issues related to COVID-19 vaccine introduction, where people were not getting vaccinated, had to do actually more with access and service delivery issues than misinformation. The point here is that you need to first have equitable access to vaccines and supply of the vaccines. And if you have achieved both of those things, then the reasons why people are not getting vaccinated can usually be attributed to the confidence or demand. So think of it as this pyramid. You have to have supply, you have to have equitable access, and you have addressed those things. And if there's still gaps between how many people are getting vaccinated and how many people should be vaccinated, then it's more likely that you can attribute it to the demand-related factors. Now, the information environment can influence demand for vaccines. And we've seen that time and again for a huge range of vaccines, whether it's for Ebola, whether it's for dengue vaccine. So for example, the vaccine challenge in the Philippines is a good example. We've seen this for measles, rubella vaccine. We've seen this for polio vaccine. And every vaccine has its own characteristics. It has its own unique factors that can make an infodemic more complex. So for example, the HPV vaccine, you know, it's an incredibly powerful cancer fighting and cancer preventing vaccine, which is the first of its kind in the world. Yet, unfortunately, it's been linked to narratives of sex, and it's also been linked to misinformation about fertility issues and long-standing side effects. And the issue is that when that happens, it's very difficult to dislodge this particular narrative, even if it's not true. To this day, Japan still has not recommended HPV vaccine as an addition to the national routine immunization schedule, in part because of misinformation. So that was one example. The point is that it's not uncommon for new vaccine introductions, or when you're trying to vaccinate people very quickly during mass immunization campaigns, and in an emergency, when you're trying to vaccinate people very quickly with newly developed vaccine, that a lot of issues that we saw during COVID-19 are going to surface also what was the state of the health system before the pandemic. There are only 4 countries in the entire world that had really strong adult immunization platforms. And we've had to see really what happens when a country has to very quickly figure out how to pivot from vaccinating only babies and children to suddenly try to find adults and trying to find populations of humans that have been prioritized for vaccines that just haven't been within the remit of an immunization program, especially in low and middle income countries where vaccination is seen as routine childhood affair only and not for adults. So seasonal influenza vaccination programs are very weak in many countries and have extremely low uptake in many countries that do have those programs. So what COVID-19 has taught us is that when you're, for example, trying to identify who is immunocompromised, that's a little bit more challenging than figuring out who is a child, who is under the age of 5, and where to find them. And the same applies for other high priority groups, such as older people. Now, the reason why this matters in the context of the information ecosystem and the landscape, information landscape for older people is how they experience the information landscape. So, for example, we know that older people were less confident about COVID-19 vaccines. They have less digital literacy. They're more vulnerable to misinformation, and they're harder to reach. So they also tend to have less internet access than younger people. And again, that can affect their exposure to misinformation, and the information landscape can influence their perceptions and attitudes related to vaccines. And that can become then a real challenge. Now, it's also worth highlighting that because this was the same COVID-19 vaccine program that was happening all around the world simultaneously. Everybody was talking about vaccines, and this probably was the one point in human history where we never had more people talking about vaccines or about one particular issue simultaneously as much as we did during the pandemic. And that meant that vaccine developments or concerns or vaccine-related events, if they took place in one country, they could very easily become newsworthy and gain traction and affect vaccine uptake and confidence in another country. So, for example of this include early issues related to blood clots for some vaccines in Europe and how that affected the debate about vaccines in the United States. Issues around concerns about swelling of the heart and myocarditis and endocarditis that also popped up among young people. And these are actually true concerns that take on more sinister perspectives and become misinformation or disinformation. And the point here is that it's not all concerns out there about vaccines that are untrue. Some concerns are entirely legitimate. So I'll give you an example here. Early on, we didn't have a lot of good trial data on how do these vaccines work in children? How do they work in pregnant women? And well, why? Because all of the vaccine trials are in healthy adults. So when we got to the point that vaccines were being recommended for broader and broader groups of people, including pregnant women and children, people had a lot of questions and people had a lot of concerns and trying to figure out the risk-benefit calculation for whether or not they should have their teenagers or their younger children vaccinated, or whether pregnant women should get vaccinated. Now, this is really important consideration because it's not misinformation, it's actual concerns, and those need to be detected as well as addressed, because if they're not addressed, they can very rapidly become breeding ground for misinformation. Then, of course, there's also worth highlighting that there are other factors that were promoting misinformation, either because this served a political purpose or served as a way for the promoters to benefit in some other way. And of course, there's also was disinformation strands around COVID-19 vaccines. But the point here is that that's a pretty small percentage of the sum total of conversations about COVID-19 vaccines. Again, actually, we don't know the true percentage of misinformation that makes up conversations about vaccines, because it will differ from country to country. But the estimates can range from 5 to 20% of all conversations. And I think it's actually closer to the lower end. But the bottom line is that if you're just focusing on misinformation, you're missing the entire conversation. And that can affect your ability to address issues related to people's concerns and knowledge related to those vaccines, which again, if you leave those unaddressed, they can become breeding ground for misinformation. So what have we learned from promoting COVID-19 vaccine demand? One, you want to reach people where they work, live, play, pray, study, and gather. You need to bring services closer to the people you're trying to leverage, people's perception of the disease. So, and say, look, everyone's scared of COVID, but here's one thing you can do to protect yourself and your family: get vaccinated. That can be a really, really powerful message, but that assumes that there are people who are not yet infected with COVID-19 vaccines, and they see the benefits of the vaccine versus getting infected naturally with the virus. It also assumes that there are social cues in the environment, that there are behavioral nudges around people that can make it the easy decision to get vaccinated. As social marketing expert Anton Schneider, who often lectures at WHO Infodemic Manager trainings, he says that if you actually want to make the decision to get vaccinated fun, popular, and free. So, in other vaccines, the disease is known, the vaccine is decades old and is well understood. Everyone understands the benefits of vaccination. No one wants to have their child to get the disease. So it's well socially normed that you get your child vaccinated. But in the context of the pandemic, especially if there's no vaccine there, of course, you're not going to have a social norm that supports vaccination in the pandemic if you've never experienced that before. What you also need to think about is how to do that. And a lot of that comes down to how you're designing your message, how you're reaching out to people, how you're outlining the benefits to vaccination, and how you're leveraging the trust between communities and health systems. This is really important because early missteps in the pandemic by some health authorities really decimated trust that some communities had in their government. And that meant that when it was time to roll out the vaccines, there wasn't a lot of trust to rely on. And it made it harder to get people willing to get vaccinated because they didn't trust the government. So early actions in the pandemic really influenced this success of immunization programs later on, whether or not the government was tracking the information or the information environment and doing social listening or doing infodemic monitoring in context of COVID-19 vaccines. The other component that is often an area of weakness is that there might have been monitoring and social listening, but not a whole lot of connecting it to public health action or using those insights for action. This is a consistent weakness that we've seen for the many immunization programs, although many immunization programs for other vaccines have probably been more successful with social listening, infodemic insights, because well, they've been dealing with misinformation about vaccines for a long time. It's not new, and it's also not new that how it affects the success of immunization programs. But during a pandemic, you have to consider that there are new twists to vaccine misinformation that were not part of other routine vaccines. So, for example, that the virus is evolving, and so is the science about the virus, and therefore the guidance is inevitably always out of date and potentially confusing. The fact that early on a lot of countries were constrained by supply issues. So for COVID-19 vaccine and then having prioritized populations who needs to get vaccinated, a really crucial step that was not taken by all countries was to recognize early on that if you're prioritizing health workers for vaccination, you have to ensure that they're confident in their decision, in the vaccines, and in their decision to take the vaccine, because then you may be able to ensure that they're confident also to address patient questions and concerns. Because if you can't even get really high coverage among your health workers, how can you possibly expect that those same health workers will confidently address misinformation and concerns and vaccinate others? So this is a really complex information ecosystem that goes way beyond just vaccinating children. Or, for example, in a way that you might run a polio campaign or a measles rubella campaign where the disease is known, the vaccine is decades old, and everything's quite well understood. Everyone understands the benefits to vaccination, et cetera, et cetera. Additionally, it's actually really important for the health system about really thinking about how science is translated and communicated. How are new findings, which may or may not support guidance related to vaccination, can also impact people's trust in government and trust in vaccines and in the vaccinators, in the system that it came out from. So, for example, early on, the pandemic vaccines were, the COVID-19 vaccines were considered to be a silver bullet. You know, they were positioned as if you get vaccinated, you know, you'll be able to end the pandemic. It's the best way to protect yourself and your family from illness. But then the signposts got moved as the virus evolved, and vaccines were evolved as well. So what it meant was that we were able to say, well, it prevents severe disease and hospitalization and death. And then later on, it became the message became, well, it prevents hospitalization and death because there were so many breakthrough infections of people who were vaccinated. And yet, people still got COVID. So that's actually a problem. And again, this relates to people's understanding of trust and the government, because the goalposts keep moving as to what exactly this vaccine can do. And maybe this is also an unfair judgment by some, because it also underpins the fact that the virus is constantly changing and the arsenal of vaccines being used against it are constantly having to be updated as well, which meant that, you know, the first it was 1 dose and then 2 doses and then a booster and a second booster. And that also can impact people's willingness to get vaccinated, because suddenly it started more looking like a flu program, and if people had really low risk perception of flu, then it becomes just a part of something that's kind of optional that you get also your influenza vaccine for. And now you had this COVID-19 vaccine, which is kind of becoming like an influenza vaccine, and it will be dealt with on a more seasonal nature, that there would be and there would be updated vaccines for it. So all of these different aspects impact people's confidence and vaccines in vaccines and their willingness to get vaccinated. So Thankfully, globally, there's no evidence to suggest that COVID-19 vaccine attitudes are affecting people's attitudes about routine vaccines in a major way. This is still, but that's still a fear that many immunizations programs have, that because people have had this more antagonistic relationship with COVID-19 or COVID-19 vaccines, that would affect their willingness to have their children vaccinated for routine childhood diseases. But thankfully, there isn't any published evidence that supports this, but it's a worry. And what's concerning is the fact that you notice in general, it's hard to respond to the next emergency if the attitudes about COVID-19 vaccines are going to be similar to the attitudes, and it might be experience that we experience next time in the next pandemic when there's a large epidemic and pandemic. So right now, it seems like when you conduct polls or surveys and you talk to people about their attitudes towards routine childhood vaccines versus COVID-19 vaccines, people seem to mentally categorize childhood vaccines into a different bucket than they do COVID-19 vaccines, which is a protective factor, I think, in terms of people's perceptions and attitudes about COVID-19 vaccines versus routine immunization. But on the flip side, what we know is one of the best predictors for whether or not someone was willing to get the COVID-19 vaccine was whether or not they had received a flu vaccine recently. So there's this relationship there between people choosing to get a vaccine against vaccinated against influenza and their willingness to get their COVID-19 vaccines. So it will be interesting to see if that relationship also bears out the other way around, because so for example, if people who got COVID-19 vaccines, are they more willing now to get the seasonal influenza vaccine? And this will make a lot of impact, or it will matter a lot when we're planning seasonal influenza campaigns or strengthening pandemic influenza preparedness through strengthening seasonal influenza programs. Again, the jury is out on these relationships of perceptions, but it's something to watch out for. What I also wanted to let you just point out from the point of view of information environment is also that, local vaccine deniers have become very sophisticated in how they push their message and get around content moderation online. And the problem is that we don't have great ways of analyzing content with artificial intelligence or otherwise that's not based on text. So people really interact and live and communicate with video and images. And if we don't have more automated and more sophisticated ways of analyzing and tracking visual content, it's going to be a lot harder to address visual misinformation in the next pandemic or the next emergency that we experience. What I also wanted to show you is these 6 buckets of what are the most common narratives about vaccines. This particularly is was analysis of COVID-19 vaccine misinformation, but actually these apply to practically any vaccine. If we think about what is within the health system's mandates to be able to address when it comes to health misinformation and its precursors, this example is very telling, because there are 6 categories and they span across development, provision, and access to vaccines, safety, efficacy, and necessity, political and economic motives, then linkage to conspiracy theories, linkage to liberty of freedom, and linkage to discussions of morality and religion. But how many of these can a Ministry of Health or a health authority really address? And unfortunately, not many of them. Out of the 6, only 2 related to vaccine development and necessity can be explained and addressed by a health authority. And in the other narrative themes, a health authority isn't best placed to address these. So really, how do we deal with this? This basically means that a health authority needs to partner with those who can address these narratives. And these may not be in the usual partnerships that already exist and that we have already built. Now, I won't go into a lot of detail here on this slide, but basically, if you think about that, you have a certain menu of infodemic interventions to consider, and that you know that you need to have partnerships to be able to complement and strengthen what we cannot do alone. It's really, really important not to only look and concentrate on strengthening the capacities within the immunization programs, emergency preparedness and prevention, but also look at partners and capacities that we need to develop outside of the health system. And for example, partnerships with fact checkers is one such an example. If you look at all of these activities suggested on this slide, they all have one thing in common. They all position the health authority within the information ecosystem. And basically, we need to use our knowledge of how the internet works and how information is propagated by algorithms and people, and how it's designed to bolster against, how we can design to bolster against common psychological and computational vulnerabilities to mis and disinformation. The bottom line here is that if you're implementing an effective infodemic management strategy, you will not only have more of a communications presence in the information environment, you will actually achieve better decisions at individual, community, and health system level when they interact with the information. Basically, when you understand conversations and reactions and feelings and narratives in a population, infodemic management can help you keep your promises and help you deliver health to communities in ways that meets their values. So I want to leave you just with one last thought, because capacities for social listening and infodemic management that you build in routine can be surged for any emergency. And that means that the investment in infodemic management can really be tiny, or can be done in tiny or in giant health systems. But we all started pedaling madly like this one guy on a bike, not well resourced, juggling too many responsibilities and serving too many needs. And if we're lucky, then we get more resources and two more wheels, and we carry a bigger toolbox. And if you're lucky more, the road is paved for your success, and we get very comfortable seats and a massive toolbox to drive and apply to many infodemic challenges. But regardless of where you are, actually, this is not determined by the amount of money poured into this activity. It's really about infodemic insights, this type of thinking about information ecosystem being embedded in immunization programs and in other programs that are dealing with infodemic questions, concerns, information voids in an acute health event, in an emergency, or in preparation for an immunization campaign. Now, I gave you quite a lot of information. What I just wanted to also point out that this was just a little bit of a program of work that WHO has worked on over the last 3 years, specifically developing infodemic management and the underlying science of infodemiology, specifically to support not only the COVID-19 vaccine demand promotion, but in general the response, and now also response to other outbreaks that are taking place around the world. There's lots of resources available, and I invite you to look them up. But tools-wise, what I just discussed a little bit, also, for example, infodemic insights or how to address health misinformation, this is really just a tip of the iceberg. We have a lot more content and tools for you. They're coming to you actually also in the form of more courses over the course of next 2 to 3 months on OpenWHO, and I really do recommend that you look them up if you're interested. In the meantime, I do invite you to subscribe to the WHO Infodemic Management Newsflash. It brings along current information, papers, events that may be of interest to you. And I hope that this discussion was a little bit useful to you when we're trying to contextualize what we learned from infodemic, how it affected COVID-19 vaccine demand, and what potentially is their learning for us going forward. Thank you very much.